Welcome, and thank you for joining us. I'm Joe Feldman. I'll be moderating today's webinar presented by the Kennedy Forum and the Employee Benefits Security Administration. When you pay health insurance premiums, you expect access to the health care you need. You expect that doctors or other clinicians will be available to see you, and that those caregivers will have the expertise and the authority to determine the care you'll need. And you expect that they'll provide that care for you and your family. This system mostly works for physical health needs, like annual checkups, broken bones, and even more significant health problems like heart attacks and cancers. Our panelists and today's audience members know that this system hasn't met basic expectations nearly as well when it comes to mental health and substance use care. I'm now pleased to introduce today's panelists. Meiram Bendat is a psychotherapist and attorney. He founded Psych-Appeal in 2011 to offer legal advocacy for patients and providers challenging denials of mental health treatments. He served as a plaintiff's attorney on numerous class action suits against insurance companies, including the landmark case Witt versus United Behavioral Health. Tim Hauser is the Deputy Assistant Secretary for Program Operations of the Employee Benefits Security Administration, or EBSA. EBSA is the federal agency within the U.S. Department of Labor that oversees workplace health plans and other employment benefits. Karen Wolownik Albert is the Chief Executive Officer of Recovery Centers of America in St. Charles, Illinois. Recovery Centers of America provides residential care and other addiction treatment services at 12 facilities across 6 states and growing. Karen's broad work on improving systems of care earned her the 2018 Bakeman Memorial Award from the Illinois Association of Behavioral Health. And finally, Lauren Finke, who serves as Policy Director for the Kennedy Forum. Lauren focuses especially on state-level legislation and implementation. In 2020, she helped enact landmark legislation in California, specifically Senate Bill 855, which has set a national model for coverage of mental health and substance use treatment. Similar legislation has since been enacted in additional states, including here in Illinois. We welcome these distinguished panelists who will help us understand the tools and resources available to navigate common obstacles faced by behavioral health providers and their patients. Their perspectives will address not only the environment here in Illinois, one of several states with enhanced protections for behavioral health benefits, but nationally, where federal oversight, litigation, and regulation of mental health continues to evolve. Karen, maybe you could get us started by sharing your perspectives on current insurance barriers for mental health and substance use disorder care.
Thanks, Joe. Hi, thanks for having us here today and organizing this very important topic. RCA is a national provider of addiction treatment services, and we still see a good deal of variability in the states where we operate and the various payers where we work. Our pillars really include being accessible to the patients who need our help and being affordable. And so we want to be an in-network provider, and we are in network with almost all insurance companies, from the large carriers to some of the smaller local plans. And it's amazing to me sometimes how hard my team has to work to really understand all of the variance nuances and the differences and the variability between the different payers and companies that we work with to be able to secure care for patients. I think in the last 15 years, we've made a lot of progress as a system in being more accessible for patients and getting patients and persons the care that they need. But I still see and hear, honestly, in addiction treatment especially, a lot of stigma and a lot of bias in some ways. And I'm not sure that we really manage, we know that addiction and mental health conditions are chronic relapsing diseases. And throughout a patient's lifetime, they're going to have an increase of symptoms and they're going to have periods of stability and recovery. And we see this with other chronic diseases like diabetes and heart disease, but I'm still not sure, well, I know we have a long way to go to really treat behavioral health conditions in the same way that we treat medical conditions.
Great, thanks, Karen. Tim, the Employee Benefits Security Administration protects about 150 million Americans' rights to equitable coverage under the Mental Health Parity and Addiction Equity Act from 2008. And in the recent report to Congress, the government made clear its commitment to realizing parity, reducing stigma, and raising awareness. What do you see as the greatest opportunities and challenges within the world of ensuring equitable coverage?
Well, I'll start maybe with what some of the greatest challenges are, and then try to be more uplifting after that. I mean, the challenges, when you get right down to it, is we're just not where we should be with respect to parity. You know, we're 15 years plus in on this statute. I think the promise of the statute is pretty straightforward. The idea, I mean, in implementation, it can be challenging, but the basic concept is fairly simple. If you are looking to get mental health benefits, looking to get substance use disorder benefits, you shouldn't face special hurdles, special barriers, impediments, roadblocks to getting access to those benefits that you wouldn't face on the medical surgical side. You know, that's a big picture of this statute, and that's kind of the central animating purpose of the thing. It's hard enough sometimes to cope with mental illness, to cope with a substance addiction, to be a family member of somebody coping with these things. That can be a job in and of itself. But on top of that, you know, to have to shoulder an extra load just to get the benefits you were promised under your plan isn't right. That's the premise of the statute. And it's not and that's kind of the promise of the statute if it's implemented properly. But right now, that's not where we are. So, you know, we're pretty far from that as a goal. And Congress recognized that, I think, a couple of years ago when it passed the Consolidated Appropriation Act. And what Congress did in that act was they gave us essentially a special tool. They gave the providers and the plans, or the insurers and the plans, a special obligation to make sure they had their comparative analyses done of non-quantitative treatment limitations, and that they had documented why these things were lawful under MAPIA and in Parity. And they told us, the Department of Labor, as well as HHS and Treasury, you know, that we, you know, they actually specified a minimum number of investigations they expected us to complete, that's unprecedented in my experience. I mean, I would take it as a vote of dissatisfaction by Congress about not just where compliance was, but about where we were in terms of enforcing this law. And so we have decided to enforce this law in a very big way, and we have made an enormous commitment as an agency to enforcing the law. And what we saw when we started to use the new tools of, you know, we have a right to get the comparative analyses on request. There's a whole process for a back and forth kind of interaction with folks about what's going on with these non-quantitative treatment limitations. Are you doing what you're supposed to do? And what we found was discouraging. I mean, it was the case the first year that we issued these comparative analyses requests, and it's the case now that overwhelmingly, in virtually every case, the initial documentation we receive has been inadequate. It's been insufficient to demonstrate compliance with MAPIA. Now, we're obviously requesting these analyses in instances where we think there's some reason to be concerned. So it's not a random sample, but nevertheless, it was surprising to us, and it's discouraging and disheartening that the analyses were as problematic as they were. And you know, they fell short in the sense that there's too much focus, I think, on papering over problematic practices, essentially trying to come up with post hoc rationalizations for decisions and plan designs that seem to have been made on bases other than just trying to comply with MAPIA. A huge premium being placed on word choice, on coming up with ways to describe fairly disparate practices using the same words in English, even though substantively the practices are very different, and a lot of kind of careful lawyering going on in the responses we're receiving, where the goal seems less to be to explain why something is in compliance with MAPIA than maybe avoiding an initial finding just based on the paper we received of a violation. So that was very, very discouraging. We tried to go the extra mile. I think we have gone the extra mile the first couple of years and recognize that this is a new process for people. We need to have a lot of back and forth, but I would say our patience is starting to run a little thin. I mean, I think you can expect going forward that we're going to insist on and expect more in the way of good analyses up front. And what's most concerning to us isn't so much that, I mean, the goal of MAPIA isn't to have really good paperwork and to be able to justify in writing what you did. The goal of MAPIA, as I said, is to make sure that people essentially are afforded the same access to promised mental health benefits as they are to medical benefits without these special impediments. And what we've seen are all kinds of problems on that score. I would say there's cause for optimism just in the following sense. We have obtained a lot of correction. I mean, there are a lot of categories of violations that people were fairly quick to respond to and deal with. This includes, for example, a number of kind of separate treatment exclusions for mental health, restrictions against ABA therapy for people with autism. A lot of, sort of those kind of things have been eliminated. And some examples of things people have done is we saw exclusions for methadone treatment that we had eliminated. People using employee assistance programs as gatekeepers for mental health benefits, but not for medical benefits. And people have agreed to eliminate those exclusions. A lot of cases where the pre-authorization requirements were dramatically more onerous on the mental health side than on the medical side. And we've seen a lot of folks fix those things, remove, exclusions of urine testing, kind of on and on, exclusions of residential treatment for mental health conditions. So we've seen a lot of these kind of things, and a lot of them were fairly black and white to our minds, sorts of violations, and people have fixed them, and that gives me some cause for hope. But that, that encompass tens of thousands of plans and millions of participants that were covered under those plans. So those are significant reforms. But the fact is, we have well over 100 investigations still going. These, in many, many, many cases, have what appear to be fairly significant violations and significant issues. And it really remains the case that there are barriers and roadblocks and obstacles to people getting promised mental health benefits that don't exist on the medical health side. And people aren't paying enough attention to those kind of disparities. And they aren't internalizing that, when you design the plan in the first place, when you come up with what these limitations are, you really should be asking yourself, am I making it harder for the person suffering from mental health benefits to get these benefits than not? And instead of focusing on the paperwork or what your rationale is or what your legal argument is, just are you stopping that kind of inequity from happening? And we just aren't there yet. We're long way away from it.
Thanks for that. When I read the report that I think you had a significant hand in this, the 2022 MPIA, so Mental Health Parity and Addiction Equity Act report to Congress, which I would commend people to look at. What struck me was that you were having trouble having insurance companies provide you with meaningful responses. And it sounded an awful lot like what happens when claims are filed and the responses from the insurance companies are also inadequate and hard to understand.
Yeah, can I say one thing that's a bit of there's an odd disconnect in the legal structure here in a way that's just worth noting, which is that in our world, in the ERISA world, the obligation to comply with parity is put on the plans. Rather than say directly on the service providers to the plans. But typically the plans are dealing with the service provider, which might be a big insurance company, might be a big third-party administrator. Those people are designing the plan documents. Those people are building the networks. And what we heard, especially early on from a lot of these folks is, why are you picking on us, Department of Labor? We're just the plan. We expected when we dealt with, this enormous insurance company or this enormous TPA that we were getting them a PIA compliant product. And I would say I have a certain amount of sympathy for that. I mean, it only goes so far. The obligation is with the plan. The plan has an obligation to make, it should be asking those hard questions. It should be looking for guarantees and for certifications or representations from these providers. But there is a fundamental problem at the provider level with the third-party administrators and with the insurance companies. And we are very, very much focused on getting those folks to fix it so they fix a problem, not just for one plan, but for their whole book of business. And I would urge anyone in this audience who represents a plan or who or is having trouble as a customer even, or a service provider dealing with these larger service providers that do practices that affect thousands and thousands of plans, please contact us with those problems. I mean, we're interested in getting them fixed at the root, not just plan by plan by plan.
That's great. I'd like to maybe take a closer look at one of the issues that's been touched on just now in Tim's remarks, and I think is going to be familiar to many members of the audience, and that's what's referred to as network adequacy. So network adequacy asks the question about whether insurers or third-party administrators are making available enough clinicians to meet the needs of the individuals buying insurance. Senate Finance Chairman Ron Wyden from Oregon recently brought attention to this issue of so-called ghost networks, where the insurers have published directories of in-network clinicians that look robust, but the information is either inaccurate or the clinicians are not available to see patients. And Senator Wyden reported that in their study, 8 out of 10 instances, mental health providers named in these directories were either inaccurate or just not taking new patients. He went on to say when insurance companies host so-called ghost networks, they're really selling coverage under false pretenses. Meiram, maybe you could touch on where insurance networks are notably falling short and what people might be able to do when they encounter these challenges.
Sure, thanks, Joe. So when it comes to network adequacy, there are really 3 issues that concern the individual consumer. And that is, one, whether they can find a suitable provider, in other words, one with the appropriate expertise for their particular concern. The second issue is whether they can locate a timely, suitable provider, in other words, someone who can see them in a manner that would allow their need to be addressed with sufficient promptness so as to get relief. The third issue has to do with geographic access. Can a suitable and or otherwise timely available provider actually be accessible geographically? In other words, is this particular provider within proximity for meaningful contact with the patient? And of course, while telehealth has gotten us far, it's certainly not a substitute for in-person treatment or for treatments that can only take place in person. So those are the 3 kind of network adequacy impediments that are really felt by the consumer. In terms of what the consumer can do, well, that really depends on where they live, who has jurisdiction over their health plan. Are they, for example, covered by a health plan subject to Illinois or California law, where in these particular states, if a suitable and timely and or geographically accessible provider can't be located, then regardless of parity, there is just an expectation that the health plans make care available on an out-of-network basis to satisfy the timeliness and distance requirements that the law requires. But again, these types of laws are generally enforced only in states that have set up network adequacy requirements that contain timeliness and distance factors, and that additionally obligate insurers to cover out-of-network services as if they were rendered in network, so that patients are held harmless. In other words, they're not supposed to be responsible for balanced billing. That in turn actually should become the obligation of the health plans. And of course, there's a public policy component to this. When health plans have to start paying much greater out-of-network expenses because their networks are inadequate, then that should incentivize them to address issues of under reimbursement and under participation in networks. So that's kind of an option for patients in the jurisdictions that regulate their fully insured plans under these appropriate laws. However, many patients don't have access to timeliness and geographic access remedies that these robust state laws provide, especially patients under self-funded health plans that really lack a federal right to network adequacy. Instead, what these patients should really be arguing for and lobbying for, with the help of their providers, is for enforcement of parity. And that's something that can be best addressed by bringing complaints to the Department of Labor and perhaps to some extent through litigation.
Great, thanks. Karen, maybe you could jump in from the perspective of having a great provider network in terms of how you liaise with insurance companies, or choose not to, maybe in some cases.
Yeah, I think, when we opened the facility here in the Chicagoland area almost 3 years ago, it was a challenging process, to set about getting into everyone's network. And so, of course, we started with some of the major carriers in our area, and then kind of, went through that process. Everyone's process is a little bit different. In some cases, it took almost 3 to 6 months after the time that we submitted our application to be approved as an in-network provider. All the time, we're receiving calls from patients wanting to come for treatment, and we could only work with them on an out-of-network basis, which was, not necessarily, a very realistic option for some of the patients. And then once we got in network with some of the major carriers, then going about some of these smaller HMO networks. And even though you're in network with a major carrier, you still need to join some of the HMO networks. And not all HMO networks were really interested in having new providers come aboard, because they might be associated with larger hospital systems with similar services and wanting to kind of keep people in that network. So, that was a very interesting and long process, I will say. Looking at telehealth, we have telehealth options through our outpatient program, because as we have people come to our inpatient program and then return home, we have people coming to our inpatient program sometimes from an hour or two away. So being able to participate in person for outpatient isn't necessarily realistic, and they might be returning to areas where they don't have easy access to in-person treatment, not just for outpatient services for their substance use, but also medication-assisted treatment is, especially in downstate Illinois, is not widely available. So I'm glad to see that Illinois has continued to kind of protect telehealth services and make that an option for some patients. We see with some of our patients too, who might have transportation barriers, or they might have childcare issues, or they might be, having to come from work and not always have time. So we do see that the telehealth services have increased accessibility for some of our patients, which I am glad to see. But it, in some cases, is no substitution for being in a room with people, which I think we all missed during the pandemic. And I hear from a lot of patients, they want to be in a room with people.
Yeah, great, thanks. Lauren, any thoughts from the, I'll say especially from the state legislation and regulation perspective on what can be done or what is being done to help with network adequacy?
Yeah, and Meiram touched on some of this, so I won't go into a ton of detail, but states really do have the power to put in place both quantitative timely access and geographic distance standards. And they really should be requiring plans to have in-network services available within those specific amounts of time, within the specific amount of, like, the distance. And too often we're finding that states have just really too weak of standards in place where they can really enforce that. So I know I mentioned both California and Illinois bills for their network adequacy regulations and time and distance standards. And I think there's just some really critical components of that might be helpful for folks on this call. And one is in California, SB 855 required commercial health plans to cover all medically necessary treatment of mental health and substance use conditions. And then we tied that medical necessity to the generally accepted standards of care as they were outlined by the Nonprofit Clinical Association criteria. So for example, if you were seeking services for a substance use disorder, you would be using the American Society of Addiction Medicine criteria. And so that's more in alignment with clinical standards of care than, sort of not having that. And, the California bill also, just to kind of piggyback off Tim's comments, is the California bill also has two important pieces. One is that plans have to adhere to those generally accepted standards of care that I just mentioned, and they have to do that sort of independent of their economic self-interest. And so I think that's sort of an important piece too. And then the second part is that plans must proactively arrange that care for out-of-network services, including initial and follow-up. And the Illinois laws also have that for initial appointments and for follow-up appointments. So while California law has this shall arrange coverage mandate on the plans, both California and Illinois both have these protections. So I think that's really important when we're thinking about what state laws and regulators sort of have as tools available to them.
Okay, thanks. Tim, any thoughts from your perspective? It looks like you've got a friend in Senator Wyden on the Hill. What's your thought on network adequacy from the perspective of the Department of Labor?
So network adequacy, I think, is probably in some ways both the most challenging issue to take on under MAPIA and the most important. And from my perspective, in a way, the most frustrating for the comparative analysis process, because what we tend to see are, in practice, what we're seeing, especially for the big plans and the big providers, is, there'll be kind of one set of people responsible for designing and overseeing the mental health networks. There'll be another set responsible for the network of medical providers. And there will be obvious disparities in how robust the networks are. And but then what we'll get by way of comparative analysis is, it'll be kind of a list of a grab bag of factors and approaches that we look at Medicare reimbursement rates. We look at a variety of metrics having to do with time and distance. We look at all of these bargaining power and market dynamics, and all these things will be kind of listed, and then there'll be a representation but we do these things the same way with respect to both networks, and those are all very big abstract concepts, none of which are operationalized in any kind of detailed formulaic way that one can readily get their arms wrapped around in as doing a comparative analysis. And I guess what I would say is, and I'll just tell you the way we're looking at it at the Department of Labor is I think the reality here is the way networks are designed and the way they're administered and the way they're overseen is kind of a function of a multiplicity of factors and variables and standards and practices. And we are at least going to assume if as a result of that multiplicity of factors and processes and standards, what we're looking at are very disparate sorts of access to the mental health network or to substance use providers on the one hand, as opposed to medical providers on another, there's a problem that needs to be addressed. And the folks at the plans and the insurance providers need to be focused on closing those gaps and eliminating that problem. And I'm going to assume if we do enough if need be, we'll halt the comparative analysis process. We'll move on to subpoenas, to depositions, discovery, but we will find out exactly what the basis of those differences are. And what we really would hope to work with providers on, with the network providers and with the plans and issuers in particular, is how can we get to a place where really just people as a practical matter have access to equally robust networks, and they can just as readily get in-network treatment on the mental health side as the medical side. That's the goal. That's what we'd like to work toward. We can have lots and lots of arguments about whether a reimbursement rate or a set of reimbursement practices on one side or the other can somehow be said to be comparable. But in the end, we want to know, well, what are you doing to fix those things? So I'll just give you this just happens to be an example from recent investigations. So I just want to give you a sense of what these things can look like to us. So we got a lot of analysis from this particular plan about why everything was in parity and everything was okay. But here, just to give you, these are statistics from 2018 through 2021. And there are lots of statistics in this investigation, but just focus on out-of-network utilization. So what we see here is in the years from 2018 to 2021 for substance use disorder benefits, one year, 97% of the payments out of network for substance use disorder. Another year, 78%. Another year, 90%. For mental health benefits, each and every year from 2018 to 21, it's a large majority of the benefits are being out of network for this particular plan. You look at the medical side, it's a small minority of benefits that are out of network. And so you're looking at these things and you're looking at it for a period of some years. And ultimately, I find that shocking. I mean, that's not the way it should be. MAPIA isn't working. It's not promoting its goal if you can have that kind of result. And when we see that, what we want more than anything else from the network providers and from the plans and from the insurance companies that are administering these things is to work with us to fix that. So that's not the reality for people in these plans. And right now it's a huge, huge problem.
Yeah. Thanks. Well, I mean, it's certainly encouraging to hear about you and your team's efforts to get after this, because this is obviously more than what an individual can deal with on their own, and it's great to have your efforts there. I'd like to turn our attention from network adequacy to another phrase that comes up a lot, and that's medical necessity. Essentially, when you buy health insurance, I think probably everyone on this call knows, insurance companies agree that they will pay for claims for care that's medically necessary. Meiram, maybe you could kick us off in this section and talk about the question of who gets to decide whether treatment's medically necessary, and how that barrier comes into play for people trying to access care for mental health and substance use disorder.
Sure. So as you mentioned, network adequacy and medical necessity are the two main non-quantitative treatment limitations that can get in the way of patients accessing care. And when it comes to medical necessity, one would think, well, a physician, a treating provider, should decide whether a treatment is indeed medically necessary for a patient and make a recommendation accordingly. And in fact, that is what providers do all the time. They make recommendations, they prescribe treatment to their patients, but based on their best knowledge of the prevailing generally accepted standards of care and what the patient's clinical circumstances are. However, in the context of health insurance and health plan benefits, as a general rule, contractually, generally the health plans get to decide whether a particular service is medically necessary in order to be covered. And so then the question arises, well, shouldn't the determination of medical necessity essentially be one and the same if, for example, a provider and a health plan are both utilizing generally accepted standards of care in order to make a decision and are both considering the same clinical facts? Shouldn't they essentially fall generally the same conclusion about whether something should be covered or not? And that's where we run into trouble, because while just about every single health plan around the country purports to define medical necessity based on generally accepted standards of care, among potentially some other considerations. And just about all providers would presumably be making decisions that are based on generally accepted standards of care. What we've found is that many health plans use guidelines, internally created guidelines or proprietary guidelines that are licensed from for-profit publishers to make decisions that may not in fact be consistent with generally accepted standards of care, but that may be tainted by financial conflicts of interest or by in theory, clinical evidence or clinical research or literature that is cited in the guidelines, but doesn't actually stand for the cited positions. So that's why we have laws like, for example, SB 855 in California and likewise in Illinois, where essentially medical necessity is defined very clearly to be consistent with generally accepted standards of care, and where it's clear that health plans may not place their financial interests ahead of the plan members, and then ultimately that require insurers to use medical necessity guidelines and standards that are developed by nonprofit clinical associations rather than internally, or that are instead purchased from for-profit entities. And that can lead to a lot more concordance between what physicians and providers recommend and what the health plans ultimately decide. And that's a good thing for patients, because then there's an actual ability to rely on the recommendations of providers and to presume in good faith that those recommendations are going to be, in fact, upheld, approved by the health plans.
Yeah, thanks. It's a funny concept that the clinician and the patient are working together on their care, and the clinician is focusing on progress. I was talking with a friend recently who said that a claim was denied by the insurance company because they said, geez, we're going to wait and see if the existing path fails first, and then we'll decide to do something different. You would never imagine a clinician saying, let's try this, and once it fails, we'll try something else. That's not how clinicians work, but that does seem to be a recurring theme with some claims. Karen, maybe you could jump in and talk about this from the provider perspective and how these different standards of medical necessity play out.
Yeah, we are in Illinois, and Illinois is an ASAM state. And so we spend a lot of time and energy training our staff in ASAM, how to document, how to organize the clinical information so it's easily, put into ASAM, so we can talk to the insurance carriers about how the patient's progressing in treatment and what their treatment needs may be. And with the exception of some out-of-state policies, most of the people that we work with to get care authorized are utilizing ASAM. But yet there's still such a wide degree of variability. And really with ASAM, you put the information in and you should get consistent recommendations out for what level of care people need and meeting criteria. And sadly, that is not often our experience. And we do see variability by different insurance companies. I've heard from reviewers myself when I jump on the phones and help do reviews. Oh yeah, we don't really worry so much about that dimension. We are really only focusing on these dimensions. And that doesn't, really look at the whole patient perspective. And we're talking about holistic care. And I see sometimes a huge minimization, in dimension 6, where we know that if we can't help a patient have a safe recovery environment, their likelihood or risk of returning to use and remaining and coming back into care in a short amount of time and having a quick readmission, which no one wants, including the insurance carrier, is at risk. And so really, we still have a ways to go in speaking the same language and having some consistency across ASAM. Another trend that I've seen here in Illinois, and I imagine we see this in other states, we diagnose a substance use disorder based on the 11 criteria in the DSM, right? And nowhere in that criteria does it necessarily matter whether a patient's using alcohol, cocaine, cannabis, other prescription drugs. It's really looking at the level of impairment as a result of their substance use. But we hear from many providers, oh, well, that's marijuana. We don't really need inpatient care for marijuana. Or, marijuana is legal now, so we're not as concerned about that. And so, but we're clearly showing that a patient's meeting criteria for cannabis use disorder, and they are experiencing, significant impairment in many aspects of their life. And then when we remind people, well, alcohol is legal too, it's just very interesting and somewhat baffling to me that we have a much harder time. And we know this when a patient admits to treatment, getting care authorized for someone who is struggling with cannabis use disorder in the absence maybe of some other substances that people might consider more dangerous. So.
Thanks. Lauren, we've talked a little bit about Illinois and California as two of the, I'll say, leading states in terms of putting rules in place. Could you maybe touch on how effective those rules are and what people in those two states might be able to do, as well as maybe other states that are coming up behind them with laws and regulatory support? Seems like we're heading in the right direction. I can't quite tell if it's happening as fast as everybody would like.
Yeah, I think there are a couple really important components that can be replicated in other states that are important that we've learned through the regulations process. In particular, the first is that it really is highly important to put in place clear, unambiguous requirements. We know that the first line of defense in ensuring that some of these things, the practices that we've all discussed here today do not either occur for consumers, or that when they do, that we do not place the onus on the consumer to move an appeal along once like a service has been denied. So the more burden we place on them to fight that process, we know that a lot of people are going to fall off. That happens across the board, but especially among mental health and substance use disorders. So removing and focusing on the barriers of those sort of like fall off points is really the effective first line defense there. We know that having really clear mechanisms for enforcement has a deterring effect for planned behavior that is what we want, the negative and bad planned behavior. So requirements should be placed on plans in a way that encourages this uniform across the board compliance. That can be done through detailed regulations. There's a lot of the more granular you can get in a regulation and letters to plans and really communication with plans as a regulator on the coverage and service requirements, I think the better. In the case of California, regulators in their draft recommendations have listed out the nonprofit criteria, and then they also call out specific services that are like most prone to coverage denial. So a good example of this is a service that is frequently not covered but is required by law is the coordinated specialty care, which is like a wraparound service for first episode psychosis. So it's really the only clinical treatment available for early psychosis, and it's also covered under the state's Medicaid plan, but we just see kind of broad no coverage of that in the private sector. So in there or in the private market. So they really they call that out specifically. So I think that's a mechanism available, and Meiram touched on this too, but the medical necessity piece is sort of how clinicians work. That's how they're working every day. And so as much as, when people are fighting a denial, as much as, we can make sure that the appeals process kind of reflects what clinicians are already doing and aligning their medical necessity notes and their guidelines. I think that's really important. So in California, again, regulators posted their appeals decisions online. They've done that for years in the IMR process. How it used to be kind of before 855 went into effect was there's these like big paragraphs of just like text of kind of what their decision was, and there was just not a lot of like uniform. It felt more like an art than a science, I'd say. And now what we see when you go online and look at those processes is it really is like bullet points of like what was the clinical standard, what was the generally accepted standard of care that they used and cited, and then what was the service outcome. And so it is a little bit more like a plug and chug situation, which I think makes it a lot easier for regulators and really for consumers and people working in appeals to see what exactly the thinking was and to really kind of put their thinking together on that. I think that is really helpful. So those are just a couple of pieces. Insurers undoubtedly still use medical necessity as a reason for denials, but I think with clear requirements in place of what I just outlined, it makes it a lot harder for them to continue to sort of use that as an out in the denials part.
Yeah, I mean, it's thanks for that. I mean, I think the words medical necessity seem so straightforward. But having encountered this with our family where we got a denial for not medically necessary and nothing more, it makes it very hard to follow up and say, well, who says who and according to what, and really teasing that out is quite a challenge.
Yeah, and I'll just add to that. I think an important component is really having those generally accepted standards of care be connected to that nonprofit criteria, so that you don't basically run up against that's not medically necessary. And then when you ask why, you kind of get this like, well, this third party administrator did it and we don't actually know much more about it. It really, that's really a cutoff point for really being able to advocate for your patients and yourself on those things. So I know Meiram already mentioned that, but just to put a fine point on how important those are.
Great. So we've gotten quite a number of questions. By the way, I don't know what the final count was, but we had over 500 registrants for this webinar. So we're clearly touching a subject that matters to a lot of folks. We had at last count almost 30 different state insurance regulators represented on the call. And so I thought maybe, I think we have time for maybe one, maybe two questions, but maybe Tim, sort of in respect of the questions that came from that part of our audience, I think might be broadly interesting. Could you maybe say a little bit about what state level regulators can do to be helpful in enforcing parity, not just for their own states, which is obviously important, but also as part of the overall fabric of enforcement and improving access to care?
Yeah, I mean, so broadly speaking, the states have enforcement authorities and both under MAPIA and their own separate regulatory authorities that are kind of complementary to what we do at the Department of Labor and parallel to it. And I guess that, I mean, two suggestions I'd have is, and we do try in our own efforts to coordinate with states, and we'd encourage the same. I mean, to the extent that we're often dealing with common providers, maybe, in different contexts, individual market versus a group market or whatever, but there are ways we can kind of consolidate our resources and approaches and work together, and we'd encourage that, and we have a MAPIA task force, we have MAPIA, we have a health regulatory office, we have quite a few people that I can put them in contact with and that we can coordinate. So they should just I would encourage that, and they should reach out to me. The other thing more generally that's on a lot of these issues, the states maybe have a better sense than anyone of what's going on in their particular marketplaces, and collecting the data on what providers are available and where the providers are and where the shortages are and all those kinds of issues. I mean, to the extent they and kind of the data collection piece of what's out there and what's happening, I think is an important assist to everything we do. And I just think we can always do better on our coordination efforts, and we always would welcome the opportunity to work with the states on solving kind of common problems.
That's great. Thank you. So one other question that came in, I think we have time. There's been discussion about how network adequacy results in a significant amount of out-of-network utilization. And Karen, I'm wondering if you could talk a little bit about what we, I'll say, as a total system can do to have more providers decide to participate in networks and not to operate outside of networks.
I think there's still many ways that the insurance plans incentivize out-of-network reimbursement rates versus in-network reimbursement rates. And I certainly think that that's something that needs to be looked at. We, in the various states where we work, we see a huge variability in the rates that are being paid by carriers for the same service. And in some carriers, it barely covers the cost of the service that we're providing. And then, really looking at just how that impacts the level of care for patients, because patients often are paying more for out-of-network services, or it really leads to a lack of accessibility for patients, which is why, it's really important to us to be in network, because we want to be available to patients and we want them to be able to use their benefits. But it's definitely something across the system where there's huge variability still.
Yeah, certainly from my conversations with a number of providers, I very often hear, I've got a nice business. I don't have to deal with insurance. I don't have to deal with low reimbursement rates. Sort of, thank you very much. That's just not good for the majority of people getting access to care.
Mm-hmm.
So as we wrap up, I thought I'd give each of the panelists a minute or so to maybe share one thing that they think is most encouraging in terms of the outlook for improved access to care. Meiram, maybe I'll start with you, and then you can hand it off.
Sure. So most encouraging, I would say, is that a number of states now, California, Illinois, Oregon, Georgia, have been moving toward the medical necessity generally accepted standard of care legislation. We've got improved direct network adequacy standards in these states that don't necessarily rely on comparability. They just kind of mandate direct standards that are easy to measure and that have immediate recourse when they're not met. I find that that's enormously promising, and I am very optimistic that if providers, clinical associations, patients lobby their state legislators for changes, that these laws can be enacted throughout the country. And I find that extremely promising. I can tell you that I see some excellent results for patients in California, and I have no reason to believe why the same can't be replicated elsewhere.
That's great. That's great. Karen?
I certainly have seen a lot of progress. I think even when we hear something on a review that starts to kind of lead into a fail first, well, have they been to outpatient treatment before? Or it kind of creeps up on maybe like a lifetime eligibility. Well, if they've been in treatment this many times, we can kind of guide people back to, but we need to focus on what's happening right now. And does this patient meet criteria to receive care right now, regardless of what's happened in the past or what might happen in the future? And so I've certainly seen a lot of progress with that. And then it's really important, I think, for all of us to continue to educate our patients on their plans. A lot of our patients don't understand their insurance plans. They don't understand their rights to appeal. They don't understand that there's resources out there if they are denied care and they want to seek additional support. And so I know we work really hard to help educate the people who come to services with us. And that's something as a system that we can all continue to do.
Great, thanks. Tim?
So I'll respond to that question, and also there were a couple Q's and A's that came in that seem related to me, in the sense that what they were saying was, well, gee, you don't seem like you or the states have much in the way of sanctions for non-compliance, and there's a lot of money to be saved by just not paying claims, was kind of the thrust of it. So what do you do there? And I guess I would like to preach some optimism on that score for a couple of reasons. One is, I think nobody should, right now, I think we do suffer from and following up on what Karen said, from kind of a universe in which a whole lot of people don't know what their rights are, and they don't know what to expect and what to do. And so there are quite a few things we can do as you can do as providers, that plans can do, that insurers can do, to get us to a a better place. And those are part of it. I think is if you're a plan and actually being MAPIA conscious and asking up front, well, I'd like to see I'd like you to identify for me what the NQTLs are and give me your analyses. And will you certify for me, please, that you've complied with the law? I have, I'm the one on the hook for this. So please do that. And I think there's a level of consciousness out there about that there wasn't before. I think providers, you all, if nothing else, you can empower your customers. We're developing more materials, but we have materials even now. Get EBSA's materials, put them on your desks, put a poster, put handouts in your offices. Let customers know. You don't have to train them in the intricacies of parity, but let them know, yeah, if you feel like you're being mistreated and on the road to getting your promised mental health benefits, there may be something to be done. We have a program of benefit advisors at EBSA. People can call us up and they'll get free assistance. They put that number out there for people and encourage them to call if they think it's 1-866-444-3272, by the way. But have them call. Just get that word out. I think it'll help. But finally, I think that nobody should underestimate the actual desire. Even, I've been kind of a downer for some of this, but these are very human problems. And like a lot of our retirement cases, our financial work, I'll be arguing with people about the discount rate they use and coming up with the terminal value and their weighted average cost of capital calculation, on valuing some asset. And I get very excited about it. And I think it's unconscionable what they did, but nobody knows what I'm talking about. And judges aren't sympathetic. That's not what MAPIA is. These are actual human beings with real stories that you can get across. Judges care about that. And you know what? The insurers care about that. And the plans care about that too. And so if you're telling somebody about somebody who's suffering from bipolar disorder and maybe a cutter and has eating disorders, and on top of everything else they're struggling to get access to their benefits because of unfair hurdles, that's a powerful thing, and you should never let that go. People, in the end, humans respond to those things, and
Yeah.
I think we can fix these problems because of just basic human empathy if we keep at it.
Amen to that. Lauren, any final words before I wrap it up?
Yeah, I mean, I agree with everyone's sort of final responses. I do think we're in sort of a moment where you see mental health in the news all the time. You hear the words mental health crisis. You see it seems like there's always a new article. And I feel like even just 4 years ago when we were starting to run some of these parity bills in California, we were begging papers to pick up just the issue of mental health so that we could hold it up and be see, this is a problem for families. I think now that is so uniform, everyone knows that is an issue as a starting point. Legislators are kind of chomping at the bit to figure out what solutions are. And we have multiple states now where we have sort of figured out some solutions at the state level, and we also have federal solutions. And so I think we're in a really good moment of momentum and with some very specific tools in our backpack to sort of pull out and say, this is the tool you use, and here are the outcomes we've already seen. And so, I do think we're in a good spot momentum wise, and that's worth celebrating and being positive about.
Very good. Very good. Well, I hope that today's discussion has met folks' expectations for learning about the current state of play with regard to barriers to mental health care access, and a bit of optimism, if not some specifics about how we can break through those barriers. We've touched on a few resources that might be available. So one that Tim referred to is a brochure that was published by I'll say his team. There are a number of others that are noted on a resource page that has been put in the chat box and will be distributed separately to all participants. There are a number of links there, including to pages that are suitable for sort of one page or suitable for printing out and sharing, that I hope people can take advantage of. I hope people will also take the time to respond to our survey to let us know how we did in any areas we might think about for the future. And finally, I just want to again thank our organizers and sponsors, the Employee Benefit Security Administration, Tim, and you and your team, as well as the Kennedy Forum. Thanks again to our four panelists, and I wish everybody a great day. Take care.